So are we ready with the live case? So first live case will actually is from Germany by Dr. Andreas Schmidt and Dr. Schneider. Well, let's see if they're ready. They're in Germany. Oh, I see them on the screen. Perfect. Can you hear us, gentlemen?
Yes, we can hear you. Hello.
Oh, beautiful. Good morning, Dr. Schmidt and Dr. Schneider. How are you, sir?
Good, good. We are fine. How are you?
Perfect. All right. So let's start. Let's see what you have for us this morning in the US.
Yeah, thank you. So first of all, thanks to the organizers to have us again here for this great Congress. Very happy to transmit here 2 cases this afternoon for us. And with me is Dr. Sopromatze, one of our interventionalists who's going to do the case here together with me. Yeah, maybe we can have directly the slides. Yeah, hopefully you can see this. Can you?
Yes. Oh, no, the slides.
Perfect. Okay. No?
Go ahead. Yes, we see them.
Yeah, okay. So here's the conflict of interest slide. And next, please. Yeah. So this is, next slide, please. Yeah. 73 years female patient with really severe claudication on the right side, ABI very low. Yeah, very calcified arteries. She received a CT after ultrasound showing a total occlusion of the common iliac on the right side, also a little bit of an aneurysm of the aorta, which actually extends from infrarenal up to the thoracic part, also with thrombus a little bit. And there was a failed recanalization attempt here on that artery. And some other diseases, actually an ischemic cardiomyopathy with a relatively low injection fraction, but she's hiking, she's walking, she's enjoying that and wants to be active, more active again. Risk factors, also diabetes. In the past, she had here some wounds. Next, please. Shows. Yeah, the CT. So you can see it's really calcified. So max diameter, as I said, 34 millimeter. And then on the right side, the common iliac artery total occlusion. Here you can just appreciate here the severe calcium from the iliacs up to the aorta. And next shows you some images here of that previous attempt. Yeah, so I think it's really quite complex. There were 3 excesses in here. One from the axillary artery with an Oscar sheath, with a steerable sheath, 9 French outer. One recurved catheter from the left, and they tried to work their way up through the total occlusion of the common iliac here on the right side. And you can see, so first of all, really dense calcium. And another problem, then there's also a little bit of a layer of thrombus across the origin of that common iliac. And the excess from retrograde right takes some very steep curves. So I think this adds to the complexity of the case. Yeah, and next, please. Yeah, so we thought now to either choose a transbrachial or axillary excess. So actually I choose now a brachial excess first, retrograde from the groin and also from the left groin for potentially later kissing stent technique. But first we have to go through. We thought maybe we need a BBAC catheter. But actually now we started already to work on that because it's really, I think, a little bit unpredictable what will happen here in that case with our wires and excess. So therefore we worked a little bit on that lesion already. And if you can switch now already onto the screen, I would directly show you what we have done. Hopefully you can see the screen now. Yeah, so here, once again, can you see this?
Yes, very impressive.
Yes, perfect, okay. Yeah, so the hypergastric is open, gets filled by a quite large lumbar on the right side. And yeah, that dense calcium. Yeah, especially, I mean, it's circumferential calcium up to the bifurcation or nearly, but then there's a real chunk that made me a little bit feel afraid, and therefore I started already. So this is a 6 French guiding from above. But first I thought maybe to work my way up from retrograde, trying to really stay in that old true lumen with 018 wires. And here's that terrible curve here, which I tried here to overcome. This is a connect flex first to get through, but didn't give me enough stability. But then I changed to another command 18 that worked. And we took a balloon up here, and first checked in different angulations where we were. I think that's okay. So we ballooned here with 4 millimeter. Sorry. Yeah, first, sorry, I thought to stabilize my access a little bit more. And I think, yeah, we ballooned before that already. Sorry, I didn't film it. So we ballooned with 4 millimeter, and then I took a 5 French 55 centimeter sheath here up across that kink, and then we took a connect 250T. Yeah, and in fact, after some attempts going around the plug, we thought now that we are again changing constantly our C-arm positions. Here you can see once again the wire that we took the right way here to go through.
Yes, I'm just going to have my panel pitch in a little bit. A very impressive calcium here, 3 failed attempts, so to say. So from a surgical perspective, when you see a patient like this who's had failed attempts before, what do you think are the other options, or what are the options available you start thinking in management of a patient like this? I mean, Dr. Claire, Dr. Schneider, if you have any comments, and of course, the other panels right here for your opinion.
So, dann können wir mal Dito Ballon.
Hi, Andre. Very challenging case.
Hi.
I think some of the things you have to think about are what's going to happen to this patient down the line in the future. She's got at least a 4 centimeter aneurysm, it looks like, that's fairly complex as well. So whatever you end up doing here, number 1, I think there's risks because the distal aorta is aneurysmal. Number 2, you don't want to eliminate options for future treatment of her aneurysm in terms of access. Certainly, even if you get across this lesion, which I'm confident it looks like Andre is already across the lesion, that he'll be able to do that, how you manage it. If you weren't able to cross that lesion, I think other considerations would be doing something with the left iliac and a fem bypass as well, if you had to do that. There was also a fair amount of common femoral disease as well that I saw in the initial angiogram, so I think that that's something to keep in mind in terms of also creating access for future endovascular aortic aneurysm procedures.
Right. Dr. Claire, you have anything to add to that?
No, I think fem would be sort of the step that I would take if I could not get through this. But I do think that's, with this amount of calcium, you've got to not only get across this, you also have to make sure that you adequately dilate this. And a single plane is not adequate to assess that. This is where I think IVUS is very helpful, or other axial imaging at the time or after the time of placement of the stent.
Right. So Dr. Zeller, Dr. Finelli, I know Dr. Schmidt is, of course, going to cross it and we're going to have excellent results. But like Dr. Schneider talked about, the concomitant aneurysm standing there, still not meeting the guidelines, but it is there, and the progression might happen. We don't know the history, but it's been stable for so long. But let's say you anticipate the progression of the aneurysm. Do you take care of this aneurysm preemptively right now because you're already in there, or you just do your iliacs, sit back, watch the patient, and then see if the aneurysm has to be dealt later down the lane? Yeah. And if intervention right now will have any bearing on the aneurysm treatment down the lane?
Well, I would focus only on the occlusive disease at the moment. It was mentioned, dimension of the aorta is 35 millimeters, so it's far away from a treatment indication at the moment. Patient is 73 years of age with impaired heart ejection fraction and function. Therefore, I would assume that life expectancy is somehow limited. So I would really focus on what is currently limiting her in her daily activity.
Genau.
Yeah, I agree with Thomas. I think the aorta is not considered a true aneurysm at the moment. So there is more ideal to focus on the Ajax and increase the flow rate. The discussion maybe could be also in which technique we can use to recanalize the common Ajax, because this is always a question in my mind. Andre did a terrific job as usual, but we know when you go retrograde, there is the possibility or potential that you can create a dissection along the aorta. That is, obviously, is not in favor of the blood flow, but can compromise something. On the opposite, going from above is a little bit easier because you can have a less risky procedure, but the target point is smaller. So depends on the situation and what you feel. And personally, sometimes I don't know which is the best strategy.
Sure. I mean, just to add on the whole thing, especially with let me ask Dr. Garcia, how comfortable are you from the technical perspective, or when do you stop to say I'm too subintimal, so-called medial, even adventitial, that I have to redirect, versus you can push yourself and try to re-enter into the lumen? Do you have any clinical, any angiographic indicators to say, okay, we are in the wrong, really in the bad plane, or let me keep going forward and let me dissect all the way up?
Yeah, I think those are great questions. Unfortunately, I've been on the receiving end of some pretty bad decisions based on that. And the calcium generally will tell you where you are, and that's really helpful here. And I think that the goal, it took this lady 7 decades to produce a little bit of an aortic aneurysm. It's going to take her a bit unless something funny happens. So I agree with Thomas. I think that just looking at this iliac is going to be important. If you did get subintimal, the last thing I want to do is go into that aorta, because then you can make things a lot worse, and I think that becomes a huge problem. But the goal here, my concern is the calcium, and I think that what Tomas just said is if we just crack this calcium and just focus on the iliac, it's critical. It's not size and perfection, it's just flow and pressure. And so if we can get to that level, then this will be a success. And I don't think we've burned any major bridges here if we follow that kind of paradigm.
Right. So just any concept of re-entry in these cases? I mean, I've seen people do fancy stuff, but you're subintimal, you really want to go back in. Do you use any facilitatory devices to try to get back in, or you just do your wire catheter technique and try to find the correct plane?
Dilatator, 7 French?
I've done the outback back in the day, and I got to tell you, it's in my talk. I think you got to keep your wits about you when you start putting re-entry catheters down in the distal aorta. It's not that it's a bad thing with a hypotube, but if you start going up into the aorta and start poking around in there, it's a 6 French hole, and it does create a bigger problem. And so the aorta I'm nervous about. The iliacs I'm less nervous about. But if you ever get into that kind of craziness, what they did originally, which is stop, is the right answer.
Okay, great, awesome.
I think especially in the setting of an aneurysm,
yes,
the re-entry thing may be problematic in terms of treating the aneurysm. She's 73, she has heart failure. Her risk is much more significant from her heart than it is from this aneurysm, at least for the time being. But, when she's 80 or 82, if she does survive to that time and she presents with that, you don't want to be in a situation where you've kind of shot yourself in the foot in terms of treating the aneurysm down the road.
That's true.
So I like the concept of trying to stay interluminal here.
Beautiful. All right. Awesome. Great. So I think by the time Dr. Schmidt starts to work, we just probably will start with the first lecture, and then we'll come back to him and we'll follow up on where he stands right now. So the first lecture is by Dr. Lawrence Garcia. He's the Director for Vascular Services at St. Francis Hospital, and he's going to be talking about algorithm of crossing complex iliac CTOs, wires, catheters, and other devices. Welcome, Dr. We'll go back to Germany. We see some balloons expanding, so that's a good sign, I guess. Dr. Schmitz, you have some update for us?
Yes, we have. Sorry, I just have to exchange the sheath. In a second, I can show you something. So sorry, I have to go back here. So wire passed, and then, in fact, we also did an angiography here somewhere. Here.
So which wire did it eventually cross?
Connect 250T.
Okay.
Yeah, nice wire. So here, in fact, I was not really sure, did I re-enter too high? But at the end, if we look at the calcium here, I think it's really at the end of the calcium road where we re-entered. So therefore, maybe okay. Otherwise, yeah, maybe I would have once again tried to pass at another spot. And this is the other angulation. Also here, you get a little bit the impression that it could be a little lower. But at the end, looking to the calcium, was not so unhappy with that. And then we did some IVUS, and maybe we can go to the IVUS.
Great.
How can I play this here?
Hey, Andre, it's Lawrence Garcia, but as you're getting your IVUS, did you have a CAT scan before to tell you where that artery entered? Was it higher or lower to that level? Did that help at all?
Yes, actually, there was, I didn't have the impression, actually the slices were relatively rough, so no thin slices, but I didn't have the impression that there was too much thrombus roof going up here to the aortas. So therefore, yeah, I think I'm happy with this, what I see here. And when I see to the IVUS, hopefully, it's a little bit hard. Hopefully you can see the IVUS.
Yes.
So once again, this is going down. But this is now the common iliac, but once again, it starts proximal. So here, open aorta. And then at that, not here, but at that point, it goes to the thrombus, and only 5 millimeters lower, it was entering here the calcium, and there was a complete ultrasound shadow where we couldn't see anything. And then we measured the common iliac, and not sure whether I can show this here, but it was an 8.8 millimeter, what we measured here in diameter. Yeah, 8.8, maybe a little lower. First I thought, by eyeballing, I thought, maybe I take an 8 in or 7 because she's such a small lady. But here with this calcium, we thought then, maybe we take a lithotripsy balloon, 9 millimeter, the L6 balloon. After predilation, it went actually nicely in. So predilate with 4, and this is the L6 9 millimeter.
Could you switch to angio?
Right.
Angio, please, angio. Can you switch to angio? Yeah, here. So here it opens then slowly. And I mean, maybe not so much from the IVUS, but from the angio, from the X-ray and the different angulations, I think I'm really intraluminal and the calcium is around. And therefore I thought this could be a very good idea. And this is here with 3 atmospheres and after the shocks and 3 atmospheres here. And that worked really quite nice here. So long path, and here once again, so we did the lithotripsy the whole way down. Here once again, distal also quite calcium. Then she felt it with 1.5 atmospheres, but we could actually open the balloon here. Yeah, that's actually where we are now.
Yeah, that's very impressive. So just for the panel, I mean, besides the sizing of the vessel, how often do you use IVUS in cases like this? Would you always use it 100%? Or you're confident enough that my re-entry is good, my plane is acceptable for me to put a stent in without having any complications?
Yeah.
Dr. Genovese,
we have different problems with IVUS. Okay, sorry.
I think particularly when you have a degree of calcium where you really do get the anatomy, I don't tend to use IVUS to size for that or to see where my reentry is. I typically, when I do aortoiliac work, I usually have a CT scan prior. It gives me a little bit more of a preoperative planning. I know my sizes, so I'm usually using IVUS. I'm concerned I'm really in that more extra, that more adventitial space, and I may want to bail out at that point. That's mostly when I'm using it, or if I'm unsure exactly, but typically I'm using my CT scan prior.
Dr. Schneider.
No, I agree. For iliac cases, I use it selectively. Like Liz said, we almost always have a CTA, which allows us to get the sizing and to understand a lot of the disease with CT. However, I think in a case like this, when you have a reentry at the bifurcation, you're not exactly sure where it is, that's very important to know. Because if you're stenting oftentimes with kissing iliac stents, if you had a reentry, you have to make sure that your stents are proximal to the reentry or you're going to have problems. And IVUS can be very useful because sometimes it can be hard to sort out angiographically.
Right. Let me, go ahead, Dr. Claire.
No, I was just going to say that it's not only important at the time that you're re-entering to assure that you're intraluminal, but I actually think it's very helpful afterward in addition. I have a CTA ahead of time too, but particularly in situations like this where there's extensive calcium, it's already been a difficult revascularization or at least wire passage. I want to make sure that that's right. I want to make sure that the stent is adequately dilated when I'm done. And sizing, I'll usually combine the two even because it gives me a little more confidence even than the CT scan alone.
Sure.
And I think also the decision to use IVL lithoplasty, if you're subintimal, it's probably not going to be so effective and may not be such a good idea. So I think it was nice that the IVUS confirmed that they were intraluminal, and then there was more rationale for using the shockwave.
Right. So just for Dr. Zoller, would the thrombus burden have any bearing on your definitive final stent strategy usage, one versus the other, or it still stays the same? Anything changes?
Well, it does not have an impact on my stent choice, to be honest. I was a little bit, hesitant when I saw the sizing of the IVL catheter. It was pretty big. It was appropriate regarding the vessel size and the degree of calcium. But my concern here was definitely if you use a big balloon 1-to-1 sized according to the reference vessel diameter, in a lady with a relatively short history of claudication, there must be thrombus because there was no intraluminal calcification. The majority of the occlusive material was composed of thrombus. So I would have been really a little bit hesitant to use such a big balloon in order to potentially squeeze some thrombus away, either downstream, ipsilateral, or pushing it in the crossover fashion into the left iliac artery. So I would have used a smaller balloon, size. And then going directly with the stent.
That's amazing, yeah. So this is after your shockwave and balloon angioplasty, right, Dr. Schmidt? What's your next strategy? What's your next plan? You happy with this? Are we ready for stents, or you want to do something more about it?
No, I'm happy with the balloon opening of the lithotripsy balloon. The 9mm really opened up nicely. Yes, Thomas Seller said maybe some risk with thrombus. Yes, of course. So therefore, certainly, although maybe not really necessary, if it would be chronic disease to do kissing, I will do kissing here, not to have some thrombus on the left side. So now these are now the B-Graft Plus covered stents, 957 from both sides. Just figuring out which level is here the best one. And I think one level is one plane is not enough. I'll do another shot like this. Nochmal etwas einatmen. Halb ausatmen. So bleiben, bitte.
Did you IVUS the left side as well for sizing, or is it just purely based on your CT or angiographic evaluation?
Yeah, CT, and I thought, well, if on the right side it's 8.8, I could also take a 9 to the left side. In fact, I think usually I would take an 8 in, but I thought because of the thrombus, maybe really good to have some bigger stents proximal, which flare a little bit. So I plan actually not to implant them with force, maybe leave some residual stenosis for the stents, but proximal I wanted to have them with 9mm. Of course, I could have postulated them with 9. So this angulation, I think, is okay.
Yeah.
Could be lower, but I think it's better to do it like this. Mm-hmm. What do you think?
Any comments from the panel? I think it looks good though, but.
Yeah.
Yeah, maybe a couple of millimeters lower could be also nice, that you can cover better the right side on the iliac.
Yeah. A little lower, okay.
Yeah.
Yeah.
I think IVUS could be very useful because then you can realize what is the landing zones in the upper portion and lower portion.
Yeah, but keep in mind these stent grafts do foreshorten a little bit when you inflate them, and there is a high thrombus burden in the aorta. So it's probably wise to position the stent grafts a little bit more up, then you would do it usually with a pure atherosclerotic plaque here.
Ja, noch einmal etwas einatmen.
Yeah, the problem is the thrombus. That's for sure.
The true origin of that aneurysm to that iliac is the challenge, right? Because when it foreshortens a little bit, you may lose it. So I think staying where he is, yeah, I mean, you have like 2 or 3 millimeters you can pull back, but I agree with the foreshortening issue. That's a challenge. And one other thing I always point out to the fellows is when you look at the bladder, it should be circular. If you do have a complication with a bleed, it almost looks like a Hershey's Kiss. It gets pushed over, and none of that's happening here. So these are all clues that despite the IVL being so big, it really didn't tear. It stayed, it gave the in situ calcification fracturing.
Yeah, I think that's very important, especially the IVL sizing, like you talk about. At one end, we have a 9.0 vessel. In the middle is almost 100% occluded. So trying to size your shock wave to make sure you don't cause much damage, I think, is an important determinant. That's why Dr. Zeller brought up the point of having a lower size balloon to expand so that the thrombus doesn't go up. But yeah.
And I think it was pointed out with the IVS is that we have a lot of more medial to distal kind of calcium. And while it is difficult to kind of go straight up with a 9 in this kind of a disease, really, it's a low pressure balloon. You're only going to 2 or 3 atmospheres. And really, if you're appropriately sizing it to 1-to-1, then you should be getting that transference of your energy throughout that entire degree to really get your full calcium modification.
Right. I think that's a great point. So we see them going up with the stents bilaterally, which I think is great. So the stent expansion, I think, also gives you a good idea of how well you have done your pre-dilatation, if anything else needs to be done post on it. But are you happy with the expansion? The way it's just right now, the balloon is expanding. Any comments on that? Any indicators you look at to see if it's not doing well versus doing well?
1, 2, 3, runter.
Sardar?
It looks fabulous now. There is only this one indentation on the left side, which the IVL balloon was also not able to tackle after 3 runs, I believe. This might be an area where we need to do a post-dilation, but otherwise it looks very good.
It's very well expanded, yeah. So I think very important, like Dr. Spence is doing, having multiple views to really determine where your placement, sizing, and the deployment of the stent is there, which Dr. Garcia talked about, just being cognizant of the fact that we don't end up in trouble, especially with all indirect markers like having the bladder and all those things to look at. All right, so do you want us to wait for the angiogram and then we'll go for one quick talk, I guess? And then you can do a PT or IVUS.
Give a talk and we continue with another stent, distal and post-balloon maybe. What do you think?
Perfect, yeah, no, I think that's a good idea. We'll go to the next talk. All right, Dr. Smith, where do we stand?
Fine, yeah. Yeah, I think we're done. Can you show this? Yeah, here. So this is the implantation, the 2 9x57 B-graft plus grafts at 5 to 6 atmospheres started to be painful. And thereafter, we also did an angiography here. Yeah, a little bit of bleeding into the wall. So here we thought first to continue with the B-graft, but then because of that angle in that artery, and we didn't want to balloon here once again, we added here the Viabahn. This is the angiography thereafter. I think the position is very good. We post-dilated here proximally, gently with 2 10, 20 millimeter balloons. They opened nicely, and this here is the result. So I think it's a nice result. Quite happy.
No, it looks amazing result. I mean, the way the complexity, the calcification, and the trouble you had, especially the multiple attempts, I think it's very impressive how you were able to define, and do your final definitive therapy. Any special comments from the panel? Dr. Zoller, Dr. Finelli, Dr. Garcia?
Messerlein? Messer?
Probably simply congratulating Andre to this outcome and for choosing a flexible Viabahn to extend into the distal segment of the common iliac artery on the right side, because this area did show very significant kink at the beginning of the procedure. And if he would have used another balloon expandable stent, that could have resulted in some trouble, in some kink of the stent graft. So Viabahn use here was a very good indication.
Amazing. So just to follow up on this, how do you follow these patients in your outpatient? Once you're done, you have great results, you're happy. What's your usual protocol when you see them in the clinic? Do you get a CT? Do you get an RT? Or what do you do?
Yeah, we can use a CT, that's for sure, because we can check also the aorta, and definitely also from a clinical point of view, you can follow how the patient is doing.
All right, from a surgical perspective, anything different?
Yeah. We'll use CT at the initial return. I do that primarily for aortic occlusions that I've treated to make sure that we've gotten adequate expansion of everything in good positioning. But long term, I simply follow these people with duplex after the first visit. If they have normal appearance and everything, annual duplex I think is fine with an ABI.
Beautiful. Dr. Garza.
Yeah, no, I was just going to add that for us, when we do aortic work with a stent, then we do the CT. I'm like Dan, I like just following them symptomatically in an ABI. Initially, whatever pulse you have is the best you're going to get, and so following them from there and whether or not there's symptoms. We've had the experience with people staying open for 5 years with an aortic stent, and all of a sudden they'll shut it down out of spite. So there's where the CT scan can become very useful.
Beautiful. No, let's congratulate Dr. Schmidt and the team for an excellent case presentation. Thank you so much. We're going to wait for your second case coming up soon.
Thank you. Thank you.